Morning or good afternoon, depending on where you're calling from. Thanks for joining us today for our Systems for Action Research in Progress webinar series. My name is Carrington Lott. I'm the Deputy Director at Systems for Action. And if you're not familiar with Systems for Action and haven't joined us for our Research in Progress webinar series before, we are a national research program office funded by the Robert Wood Johnson Foundation. We're housed at the Colorado School of Public Health in the Health Systems Management and Policy Department. And one of the main activities that we do at Systems for Action is release annual calls for funding, where we're asking people to submit their innovative ideas of aligning systems, whether they're aligning across delivery or financing systems. And we're particularly interested in ideas that are aligning across the public health, medical, and social service sectors. Today, you are going to be hearing from a team at Case Western Reserve University, along with their partners, Better Health Partnership and Greater Cleveland Food Bank. And they're going to be talking to you about their project titled Food Insecurity and Social Needs of Low-Income Pregnant Individuals. This is their second Research in Progress webinar series. They're in their second year of their 3-year project. And so you're going to be hearing some updates as they're about midway through their project. And I know they've been doing some great work. And I'm excited to hear about what's been going on this past year since they have been with us in our Research in Progress webinar series and have presented in the past. Elaine, can I get you to go to the next slide, please? Thank you so much. So before handing it over to the research team, I do want to give a couple of house setting items. I want to go over some of those items. So this is the agenda. We're at the welcome now, and I'll hand it over to Dr. Elaine Borowski and Dr. Christopher Mundorf, who will talk about the project. And then we'll hear from Alyssa Glenn, who will be joining us a little bit later, who will provide some commentary on the impact of this research from a community perspective. And then we'll reserve some time at the end of today for questions and answers. We're going to aim to save about 10 to 15 minutes. But if any questions come up at any point during today's webinar, please locate the Q&A box at the bottom of your Zoom screen, enter in your question, and we'll make sure that we address it at the end of today's session. Last item is that today's session is going to be recorded, so we will email out the recording as well as a PDF of the slides from today. So that will be shared with you after today's session. Okay, I think that's it. I'm going to hand it over to Dr. Elaine Borowski, who you have come to hear from, and she's going to give us some great updates.
All right, thank you, Carrington. Thank you, everybody, for joining us today. We have I feel like an exciting update to provide. So today, 3 of us, as Carrington mentioned, Chris and I are going to tag team the major part of the presentation, and then Alyssa's going to join us towards the end, and I just realized I spelled her name wrong. Sorry, Alyssa, to join us to give some of the commentary. Just as a quick introduction, I'm a professor in the Department of Nutrition at Case Western Reserve School of Medicine. Chris Mundorf is the Director of Data Analytics and the Chief Strategic Analyst at Better Health Partnership. And they administer our CHW Pathways Hub, which you'll hear more about. And then Alyssa Glenn is the Director of Community Health, Nutrition, and Measurement at the Greater Cleveland Food Bank. So what we're going to provide you is an update, and just again reiterating the name of our project is Nourishing Beginnings, and it is a partnership between these 3 organizations. And, you know, with all studies like this, it couldn't be done without an amazing amount of hard work and expertise from a lot of people. And so including our teams at each one of our organizations, but also the group of really wonderful community health workers who introduced Nourishing Beginnings to all of their clients. Of course, we also want to acknowledge our funders, including Robert Wood Johnson, which has allowed this program to launch and to be successful. So today, Chris and I are going to tag team it. I'm going to start by briefly introducing ourselves and our study, and then focus on current status and to give you a little bit of preliminary findings. And then Chris is going to focus the second half on our goal for sustainability for the program and how QI inquiries have been used to help in this process. So since this is an update, and I realize not all of you know much about the project, but in order for us to get kind of into the deeper parts of where we are, I'm going to do a very brief opening or overview of the study. It's basically a community-based intervention study, and we're looking at the impact of delivering medically tailored groceries to low-income, currently mostly all Medicaid-eligible pregnant individuals when it's facilitated by a community health worker who not only helps facilitate the access to the food, but also addresses other social needs. It involves, as I mentioned, it involves many different systems from the food bank to this community health worker hub, to something that's coming on board, which is Moms First, and academia. So in this project, in this intervention study, clients are consented and then randomized to one of two groups. The first one is every 2 weeks, they receive a box or two of medically tailored groceries that are prepared by the food bank. It's customized by the household size and the preferences by the individuals. And they receive those delivered to their homes every other week. Or they're randomized to the group that we call the cash assistance group, which gets $30 in cash provided through Cash App or another online system, but I think 99% of them use Cash App every other week. And then eventually we are going to compare them to each other, which you'll see some of that today, but also a concurrent match sample from the local Medicaid data. So our overall goal will be 160 patients or clients in the study with 80 in each of these two arms. Our key data collections are at baseline, 8 weeks after the intervention begins, at or near delivery, depending on when we get a hold of them and when the delivery happens, and then 3 months postpartum. And then I know that I think Sedina said she would add in the chat, we do have, for those that are more interested in the details of the study design, we do have a paper published in Contemporary Clinical Trials that you can access. And that'll give you a lot more detail about everything from the protocol to the intervention. And so going back to our RWJ aims, we have 3. The first one is basically to do what I just said, which is to test the impact of this program. The second is to simultaneously conduct these continuous quality improvement analysis to basically address implementation issues, and with us now looking at sustainability, and Chris is going to focus on that. The third one is an expansion into a public health public health referral source, which is Moms First. We're not going to talk about that today, but stay tuned. It's onboarding, and we'll be able to update you on the next one. So this is just briefly a conceptual overview of our study. On the left, you see our 2 intervention groups, and then our comparative group of matched controls. Ultimately, we're interested in these longer-term health outcomes that are on the right side here. When you're looking at it, but when looking at these, our primary outcomes are basically gestational age, birth weight, and NICU stays, partly because of the fact that these are tied so tightly to potential long-term support of the program. And then in the middle are what we call our intervention targets. And these are the things that we hope that the intervention impact, but also believe that they serve as mediators between, and, having an impact on the outcomes themselves. So it might be that hopefully that an intervention improves diet or improves, reduces stress or improves depression. And that in turn also has an impact on these outcomes. I won't talk about it, but there's a whole series of moderators, which mean we're just looking to see basically under what conditions the intervention will work and for whom. So quickly, basically the system is that the population are Medicaid-eligible pregnant individuals. They then first are enrolled in this CHW hub. Again, we're not going to talk a lot about it, but Chris can probably highlight a little bit more of it in his section. And then of those that are enrolled in the hub, they are approached about enrolling into Nourishing Beginnings, and then they are randomly assigned to one of these 2 groups. Once they're identified and consented and we get our first baseline data, all participants receive $100 in cooking tools. They have a cool little checkbox that they tell us what things they need in their kitchen. It also tells us a little bit about their home environment. They obviously receive ongoing community health worker resources during their whole pregnancy. They also are told about SNAP and WIC and other kinds of healthy food options. But then they are randomly assigned to one of these 2 groups. And as I mentioned, we won't go into them too detailed, but basically one gets a food box, which is delivered every 2 weeks. They also get a pantry box that has spices and oils. What's really unique, I think, about the food box is that the food bank creates 2 to 3, sometimes 4 recipes that go in the box that match the food in the box. Now, not all folks actually use the recipes, but we have learned that sort of like a HelloFresh approach. On the cash side, then, as I mentioned, they receive $30 in their Cash App account every 2 weeks. I'll just mention very quickly that $30 does not equate to the food, but we are limited to the $30 because we can't go over $600 in a year. And so that's the maximum we can offer as part of the intervention. They're also helped through a navigation process called Fresh Finder, which identifies where food is available throughout the city. And they also get a cookbook, and everybody gets basically nutrition education and other feedback tips. So here's our current progress. So we have enrolled or consented 82 clients. Of these, 76 of them have been randomized equally, nicely, 38 in each of the arms. 6 are still pending randomization due to the original baseline data collection. As you can see that we have 28 that have gone all the way past out to the 3 months afterwards, and we've had 45 babies born. One pregnancy loss in the process. And we have 36, you'll see, we have data on the 36 of those 45 babies so far. It takes a little bit of time to come through the system for us. So we do have 5 agencies working with us and 9 CHWs that see clients and recruit for us. All right, so this is just a brief demographic characteristics to show we're very pleased by this. As you can see, obviously the largest group is between that 25 and 34. It is predominantly African American. There is about a 6% Latino population, but probably more so it's important to us is that the education level is quite low in comparison to Cleveland in general, with only 11% having more than high school education. So education obviously plays a very important role in this process. So this is what they're coming into the study. This also shows you the high risk of individuals. Over 60, 2/3 of them have had a child before, had a birth before. What I've tried to do is give you the sample and what we know where we can find national averages for these data. And what you can see is that in general, they are a much more at-risk pregnancy group than the national average. Almost a quarter have had a prior low birth weight. Nearly half of them have had prior miscarriages, a quarter having pregnancy loss after 20 weeks, et cetera. This is, so as part of the dietary collection, they do something called the 24-hour food recall, which is tied to something called the NDSR. And I won't go into details, but they call them once on a weekday, once on a weekend, and they basically acquire listing of everything they've eaten in the last 24 hours. And then the computer system of the NDSR system then spits out lovely amounts of data that allows us to then compare. And I'm only going to focus here on the healthy eating index, but you can see that on the right side are the averages. So if you want to compare, there's a comparison group for generally pregnant women, non-Hispanic Blacks, and all Americans. And what you see in our Nourishing Beginning population is that they are significantly lower on almost everything. You see that overall their HEI score is quite significantly, particularly considering that they're pregnant, that their overall baseline score is very low. And one of the things I noticed that was not surprising, but they are significantly higher on the added sugar. And so these are things I think that for the food bank also helps to really figure out where the focus may need to be in terms of what is delivered in the boxes. All right, so I'm going to go over it, and I just want to reiterate too that these are very preliminary. These could change on a dime, right? This is a small sample, but it is a pilot study, and we do feel comfortable sharing it because I think it helps others to know whether this is, helps us to know too whether we're on the right track. So as you can see here, this is comparing the food and the cash group on our primary outcomes. Now you see on the right side that nothing is significant, so the groups do not differ. But what you do see in general is that the birth weights and the gestational ages are higher in the food group. They are less likely to have a low birth weight baby or a preterm baby than the cash group. And they are much less likely to have a NICU stay. But again, I just want to mention that this 6.3 is 1 child, and this 2.5 is 5 children. So these are small numbers. Obviously, we only have 36, but at the end of the study, we will be able to say much more and we'll have much more power. But I think what we see here is that the trends are going the direction that we anticipate. And obviously, when we compare this to the match survey, match folks will have a better idea as well. And then this is just a quick wanted to show just the changes in the intervention targets. We haven't really dove into these either ourselves, but what we see, for example, is food insecurity has dropped quite significantly for both groups. The groups don't differ, but the time over time is significant for all of these. So all the intervention targets had a change. Now, we also know regression to the mean and things like that, which could be causing these. But we also see, for example, reported stress is reduced. And you'll see here where the cash group starts out higher. And so in our further studies, looking at our analysis with multivariate, we'll have to control for some of these things. Similarly, the depression, what we see is the food cash group started high, but both basically you see a reduction in depression and you see an improvement in healthy eating efficacy. All right, so that was a very fast, but I wanted to at least give you some, hopefully some inspirational, because it's inspirational for us as well. When we started this, we had really no idea whether or not this would make an impact or not. And so what we see this and through our qualitative work is that the folks really do like the food delivery, and there's much to talk about in the future. So I'm going to now turn this over to Chris, who's going to focus on the second part of our talk, which focuses on our aim 2, which is on QI and implementation. So Chris, I'm going to hand it over to you.
Thanks,
To you
Elaine.
now.
And thanks all for this opportunity. Thanks for your time over your lunch break. As a part of my role in the study, I work for Better Health Partnership. We do clinical quality improvement work across the hospitals. We also administer a program through Medicaid managed care plans in the state of Ohio called Pathways Hub, where through activities by community health workers, they're reimbursed as like a fee-for-service kind of reimbursement schedule from payers. And we are sort of the central hub, as it were, of facilitating payment and tracking outcomes across those CHWs. So I'm kind of wearing both hats through Better Health. One, sort of helping to facilitate sort of a standard backbone support of the CHWs as they administer part of the study. And then also the idea we had of working with RWJ and the folks here that kind of laying out a quality improvement mechanism in here. Because it's
Chris, I'm sorry, I don't mean to interrupt you. Do you mind maybe speaking a little bit closer to your mic? It seems that your audio is coming in a bit low.
I'm sorry about that. Is this any better?
Maybe a little bit.
Dear. All right, is this any better?
Yeah, just a bit.
All right, sorry about that. I'll try to speak louder. I apologize for that. I know that's always very frustrating. I got my mic right next to me. I feel like I'm Paul Abdul. So what we wanted to do is we wanted to look at consistency in the deliverabilities across the community health workers in terms of outcomes and looking at any positive deviance, kind of applying a Six Sigma mentality of providing reliability across all of the mechanisms of the study. Next slide. So as Elaine discussed, there's kind of a broad process of getting people into the study, that they are referred as sort of eligible. Either they have care coordination needs, they're on Medicaid, and they're early enough in their pregnancy where we can really kind of do the right work through them. They're then enrolled into our care coordination program, which is the Pathways Hub, and then they're approached about enrolling into the study. So we want to sort of track of how well we can do this to help overall in that process. Next slide. So the concern we have in this overall area is that we have quite a number of folks that are eligible to be a part of the study that we're approaching and that we're wanting to get them involved in the study, but quite a large number of them are not being reached in time. So their community health worker is reaching out to them and they're just not able to get enough answers. Very few people are turning down the study, but it's just through the process of missed calls and wrong addresses and wrong numbers where we're just having a lot of problem in that area. So we've done a lot of quality improvement work of really kind of digging into understanding what might be driving that variability. So next slide. So a metaphor I've used in sort of our quality improvement work is, a basketball metaphor, that if we wanted to score more points as a basketball team, we'd want to not only look at how, our field goal percentage, like how many shots we're making, how many shots we're taking, but also referral or in terms of the possessions, because, you can't make shots you don't take, and you can't take shots if you don't have the ball. Likewise, we want to kind of keep track of all these things in line to really kind of look at where the dissonance may be occurring. Next slide. So overall, we're continuing as we reach out to more and more entities with our payer partners, our hospital partners, our county partners, we're getting more and more referrals, and we're able to get more referrals in this past first half of the year than we did all the prior last year. Next slide. We've also done a very good job of getting folks enrolled into the care coordination process. So overall, about more than 2/3 of the folks are able to be enrolled into the care coordination program before they age out. Next slide. But the real major problem is that we're not able to get them into the study in time. So this is a big problem. So it's not a matter of they're not reachable. So they're having some outreach by a community health worker. The information's good. It's just that something's falling through of getting them into the study. Next slide. And this really kind of demonstrates the decoupling of these two metrics as we kind of move forward, of understanding how we can get better, of getting more people into this program, not only for statistical power, but also that we think this is a good product that we want to get as many folks involved in as possible. Next slide. So there's a lot of variability between the different agencies that administer this process. So again, some agencies do quite well of getting folks into the study, others not so good, but they've all kind of, there's been a sort of a bundling in this past year in terms of getting into the study. Next slide. And I think this really demonstrates the problem we're having of sort of overall variability, that we depend on quite a number of community health workers to go out and really kind of do this work. And here I've mapped all the community health workers that we sort of work with. On the x-axis is the number of referrals they received, and the y-axis is the percentage of those referrals they were able to convert into a study enrollment. And you see a huge amount of variability. Next slide kind of demonstrates it a little bit more. We see, kind of almost like an ANOVA of sort of like agency differences, but then also CHW differences within the agency. So you have an overall sort of aspect that's sort of masking sort of variability that might be happening with, how different agencies approach different clients. So whether it's a hospital or whether it's a community agency, and then the variability within those agencies of how good those CHWs are at being able to sort of contact the clients that they have. Next slide. And really kind of it digs into sort of, as you can tell by the chart, we have some CHWs who are doing quite a good job of getting clients into the study, while everyone else is really sort of flagging behind. That we have sort of our top performing CHWs getting around 3/4 of their potential clients into the study, while others are not doing as well. And the reason, again, we're viewing this in terms of enrollment, but this pops up in terms of all other aspects of the study, that because it's so decentralized and dependent on CHWs, that we see a tremendous amount of variability of the delivery of the services by those CHWs. So we view this as a proxy problem that to really kind of dig into what's driving that variability. Next slide. And I think this chart really kind of demonstrates where that variability comes from. And it's often coming from the turnover of a lot of CHWs, because the folks coming in are being trained through the Pathways Hub, and oftentimes getting new certificates or academic education where new opportunities are coming through. But then that means that there's always sort of a new sort of stream of CHWs that we're always training and onboarding. And when we have a CHW coming on that it's just not picking up, we get this sort of flag here. So here we have one particular agency that's our high volume in terms of dealing with folks in the study, and almost about 15 percentage points of the drop is attributable to one particular CHW who is, again, doing an amazing job working through Pathways Hub, working with their clients, but for some reason just not able to get people into this Nourishing Beginnings program. Next slide. And so this really kind of looks at, I did a new kind of axis of our active CHWs that we work with. On the x-axis is the percentage of their clients that they're getting into the care coordination program. So how good they are getting referrals and converting them into a active client that they're working with. And on the y-axis is what percentage of those clients that they're actively getting involved in the study. And this kind of demonstrates three areas of opportunity with quality improvement. Next slide. So on one end, we have CHWs who are doing great at both. So they're really good at getting clients. They're good at contacting those clients, getting them involved in care coordination, and getting them involved in the study. Next slide. Then we have some folks that are not struggling at both areas. So perhaps there's a sort of a bottleneck issue in terms of the care coordination program, but they're really struggling across the board. They're getting a lot of referrals, but they're just not contacting those clients at a very high rate. Next slide. Where I think where we focus on as a team of missed opportunities is where we see dissonance. So CHWs who are, for some reason or another, are very good at getting clients into one program, into the care coordination program, the Pathways Hub, but for some reason not being able to convert that into the study. And so this is and as you can see in each of these different areas, it splits across agencies. So there's there's an average rate for each agency, but really the success and issues driven at the study level and at the agency level who are working with is really being driven by the variability across the CHWs. Next slide. And I think this kind of dovetails into a larger issue of sustainability, because I think why we're a part of this, when we first were stewing up the idea of this project, and we didn't want to just sort of hand the food out and treat it as a project. We instead wanted to study it, and the reason we wanted to study is we wanted to sort of show the return on investment of investing into food support so that we could offer more sustainable long-term support for this type of program. And where you're getting into this, a bit of a problem here is that, and for those who aren't familiar as much with the Pathways Hub, is it's a very tricky issue of decentralized and centralized capabilities. So on one end, we have many funders through the Pathways Hub. So we're dealing with 7 managed care organizations, all with their different fee schedules. We have obviously one centralized backbone support as it relates to these across these CHWs, but they're being administered in a variety of settings, a variety of hospitals, a variety of community agencies, all with varying levels of administrative support. And so there's a bit of an issue of the lack of ability to sort of control the quality of what's being done across these different agencies. Next slide. And I think ultimately there's no right or wrong way to approach this. And it's with each sort of step across centralization versus decentralization is you gain and lose some key aspects. So one future model of this is that perhaps this could be a centralized program that's being delivered out through one agency, like a health department or like a food bank. And there you have a greater amount of assurance of quality and control of what's being done, but then you lose out on that flexibility that allows for multiple community agencies to be reaching a diverse segment of a population based off of race, ethnicity, languages, geographic location, all the like. On the other end of sort of the more sustainable model might be just sort of treating it as a decentralized grant. And what we hopefully you see here from the quality improvement data is you lose a lot of that assurance of quality control, that when it's being decentralized at the CHW level, the natural sort of outcome of this is you get a tremendous amount of divergence in sort of how the program is being administered, which makes it then harder to study and document and sort of sell to future funders. Next slide. And I think we wanted to kind of bring on Alyssa at this point, because I think it really kind of, as we really kind of develop our use case or value proposition around funding to different entities, we really believe the major sort of funder of this in the long term are payers, are the insurance companies. And at the core of this that we need to sort of address through this study is, I think, two essential questions. So as value-based care becomes the norm, as we move upstream away from fee-for-service reimbursements to sort of outcome-based payment, the central question always is who takes on the risk. So who is taking on the risk of that sort of patient receiving higher health outcomes? And whoever takes it on is going to sort of absorb their sort of biases and blind spots in administering those processes. And ultimately, I think the hardest issue that I'm really excited to bring on Alyssa to kind of comment on is ultimately when we're dealing with a medical payer for non-medical services, that I think a critical question is getting at total cost. That ultimately, whenever talking with a payer, the first question they want to know is what is that total cost of food insecurity? Because they have their financial folks that they want to know that how much can they invest in this program, knowing that it's going to sort of have the right return on investment. And ultimately, through our study that we're hoping, and we're really grateful for this funding opportunity to bake this and further develop this, that through these PDSA and quality improvement attributes, we can really look at the implementation of these types of programs to begin to answer these two types of questions. So I don't know if Alyssa, you're able to hop on and sort of comment on any of these questions.
Hi, can you hear me okay?
Yes, thanks.
I'm in
Alyssa.
kind of a, sure, yeah, thanks. I'm calling in from a kind of unstable internet connection, so I apologize if things break up, but thank you so much, Chris and Elaine, for setting the stage. And I think I want to start with just some high level kind of comments about food banks and where food banks are at. So I oversee our healthcare partnerships and really all of the work from the food bank perspective that's thinking about how do we improve the health of the population that we serve. And for anyone who doesn't know, food banks are networked throughout the country. There are 200 Feeding America food banks across the country, and in the state of Ohio, there are 12. And we work together very collaboratively. And across the entire country, I can say that we're all kind of trying to think really critically about how do we work better, how do we work smarter, how do we work more collaboratively with the local infrastructure that's thinking about the same questions, that's trying to get people healthier, because we know that food has such a critical role to play in people's health. So this project has been an incredible opportunity to work with an academic institution and then a care coordination entity to tackle some of those problems. And we're very different organizations. Like, we speak different languages, we have different kinds of things that we're working on, but in specific ways with this project and some of these goals, we're trying to do the same thing. So there have been so many learnings, and really I want to just champion the QI process generally. I think that has been a tremendously beneficial process to have along our project, because as things come up and we need to troubleshoot things, having someone with Chris's skills to really lay out the foundation of like what we're dealing with and how we can work through it and try to level set across all of our different languages has been incredibly beneficial. So I want to throw that out there. I want to encourage people to work with food banks, because we are putting resources towards these types of efforts, but there's going to need to be a lot more work on this space, because these questions, like how do we really work within these enormous established systems, the healthcare payment system, the public health system, how does this actually work at the end of the day? There are a lot of things that need to be worked through. So I'm going to leave it there for now, because I know that there are a lot of questions and I'm looking forward to answering some of them.
Do you want me to stop sharing, or should I? Oh, wait a minute.
I think either way is fine. You can leave the slides off if you want.
I'm trying to what's the next?
I think the next slide is questions.
Oh, it's questions. Okay. We'll come back to it.
Great. Thank you so much for presenting on your work and giving some updates and talking about the sustainability issues that you're probably discussing very often among your research team. Before moving into some of the questions that have not been answered yet, I want to reserve some time to see if anyone wants to discuss some of the questions that have been answered. I know Chris and Alyssa, you've typed out some answers into some questions that came in, and so those have now moved into the answered category. But are there any that you think that are important to address to the rest of the audience?
Yeah, I can comment on, there was a question around sort of other resources being offered to the families. So through the Pathways Hub program, there's a systematic process of screening each client for whatever needs they might have. And these needs may range from transportation, medical home, COVID shots, daycare, whatever it may be. And through the Pathways Hub program, they then have sort of evidence-based pathways, as it were, that they need to follow to document and treat those needs. Each of those pathways are then reimbursed by the managed care organizations. So each client gets a different array of suite of services, all dependent on what needs they might sort of engender. So some agencies do baby boxes. We do also do baby showers, like through the agencies. And again, all the agencies do it, but it's up to the agencies of what they sort of offer related to that. So I think that was a very good question.
Yeah, if I can jump into, and I think Alyssa, you could probably give the numbers better, especially around WIC, is that surprisingly, I think we only have about a 38% adoption of WIC in our state. And I think the number one reason has been administrative burden. So WIC could play a bigger role if it was utilized more. But I think there's some state level. Yeah, Alyssa, you probably could speak about this much better than I can.
Yeah, WIC has a lot of administrative burden associated with it in the state of Ohio. So you have to go in person every 3 months to load up your WIC card to get the benefits that you have. And then the benefits are so very specific. So you might make it through your checkout line with the number of food items that you think are covered by WIC, and then it turns out they're not because they're the wrong packaging size and things like this. So it's believed that the reason it's so underutilized is really just how difficult it is to use. And that's something that we try to advocate on frequently with kind of mixed success. So unfortunately, I think WIC doesn't factor in as much as we would like it to. But even with WIC, we find that people need additional resources. It's not enough.
Yeah, it kind of comes off of, I think, is it Merlandi, Joseph, I think your question about transportation is that, it is difficult to not only go and get your WIC or to update, but it is our transportation system is lacking in Cleveland. And then put on top of that we have significant food environment issues. And so, there's actually one of the things you saw is that little house, one of the logos. Our prevention center has been we basically audit all of the retail stores in Cleveland and have for like the last 10 years. Currently, there's only 11 grocery store full service supermarkets that most of you would think of as one that has a bakery and a pharmacy and things like that. There are only 11 of them across the entire city of Cleveland that stretches 26 miles from one point to the other. And so in the inner city, in the middle of the city itself, particularly, there are real issues. So you have, people relying on small grocery stores and small, corner stores for their basic eating. Do you want us to answer any of these questions in the chat, Carrington?
Oh, yeah. I was going to ask them unless you just see one that you absolutely want to answer right now.
Well, some of the ones I just realized we were so anxious to know whether we were going to be, we had so many slides, we were sure there, and then we realized now we actually had more time than we thought. So we didn't give you a lot of some of the detail, but the first question from Patricia Vale is that, so after the 3 months, after the study ends, both groups actually the food box group can continue for another, I'm going to say 6 months, Alyssa, I hope. And then the cash group can also move over to getting the food box for 6 months. So I think basically follow them for almost a year after birth, correct?
Yes.
Alyssa?
Yeah, 6 months.
Six
right.
months. Okay. So 9 months total.
Yeah. And we've had almost everyone take us up on that. I think only one person that I know of declined to receive home delivered food for that 6 months. So I think that says something about the popularity of the service.
I mean, I think what we're getting qualitatively back from folks is just from the food box particularly is just the convenience. I mean, any of you that use like HelloFresh and that, you know what the convenience is, right? And, you know, I wish I had the quote in front of me, but one woman said, you know, just, she has other children as well. And she says, you know, on a long day after work to open up the refrigerator and realize that I don't have to worry about when I'm going to feed everybody. Everything's there. And if I want to use one of the recipes, it's, I mean, I even know what I'm going to cook. So, you know, the reduction in burden at this time, the stressful time of life, I think it can't be understated. All right, so I'm looking at some of these other success of this intervention. It all depends on who you ask, right? I think that ultimately the payers, if we have, you know, there's been a lot of discussion, and Chris can talk, and Melissa can talk about this more, but there's interest in supporting this kind of a program, but they really would like to see sort of you know, a return on investment. So what's our ROI? But we have also had some of the CareSource or the Medicaid agencies say that, you know, one day in a NICU, right, you could probably feed all the families in this study for a month. So like, I think it's, you know, it's really large scale. If you think about reducing the number of NICU stays, or, you know, if you just, if babies, you know, grow and they aren't preemies, then, because well, I won't go into that. But anyway, bottom line is that that's ultimately are those primary outcomes. But I think for us, ultimate success is a reduction in food insecurity, improvement in nutrition, right, and diet. And we'd like to see these psychosocial outcomes impacted, right? So that we see the program you know, we already see it, and you saw it in some of those, right? The reduction in stress and a reduction in depression. And it's not necessarily the food, but it's the CHWs. We know that the role of the CHW is playing a large role there as well. And so, you know, tinkering with the analysis then around that will be also very important. Chris or Alyssa, can you guys see these questions? You see anything else that David Bruckman? Sorry. We know David very. So Chris, do you want to answer David's question? Have you been able to identify systematic issues seen at other pathway hub sites? It's a great question.
Yeah, we have, and it actually kind of speaks to the issue of coordination. So within our own hub, um, the clients who've been referred into this program have much better chances of getting into the hub and being contacted and like continuing on through that process, like remarkably much higher. And a lot of that's just due to the number of eyes that are keeping track of those clients, and almost like a village of working to find and track down the families so that they can be involved in this process. And again, that speaks to probably the unsustainability of that we have a short-term influx where we have the staff that can support these CHWs in tracking those clients down. And so the question we often ask at the end of a quality improvement meeting is, what's going to happen after all this is over? So if there is no backbone support to help and track down those clients, are we just going to fall back down to the average? And then that means, over the course of, over the state of Ohio, thousands of these families would not be connected to this type of care. So it's one of those bigger meta issues that I'm kind of racked by.
It also demonstrates sort of what I think, especially at the beginning, and although we're still thinking about whether it would work, but, you know, as Alyssa said, there are 12 food banks or 12 food banks across the state. And then there is a hub that serves basically every county. There's 88 counties in Ohio. Every county is served by a food bank and a hub. So ultimately, if this worked, like this could be adopted statewide. But you can see, I mean, you can see from our data how much would have to be worked through to address just what Chris mentioned. Like, how would you stay on top if once the research and being able to stay on top of every detail, you know, how would it work on its own? So
I think and that's kind of what I think Alyssa and I have spent a lot of time talking about is what's the best way to structure incentives? Because I think you currently have a model that's fee for service, whereby every little like dot and squiggle gets reimbursed like and those on the hub know it's a very small amount. If it's a value-based care outcome-based process and it's a larger amount, or is it the matter, again, this wrong pocket problem of who would need to be incentivized to get that level of quality assurance to be, that's the dream, is that do, how do you sort of improve that compliance and oversight, and where can the funding go to best support that? Is it at the organizational level? Is it at the CHW level? Like, I think that's where a lot of folks are thinking about. And that gets into the total cost of care, because then that what is the pot of money of that we have to use to work on that? And then you can start to finagle of like how to divide that up in different types of incentives. But if that pot of money is small, if the total cost of food insecurity ends up being much smaller than we anticipated, then our leverage is much weaker than we had hoped.
There's a question about, have we seen an issue in people buying non-food items with their cash? This is a question we get a fair amount, actually. And we talked about it a lot when we were structuring how the program was going to work. So I think it all goes back to like the philosophies of how we think that these different arms may impact people. And at the end of the day, where we landed was maybe it doesn't matter. Maybe it doesn't matter if they're buying new food stuff. We're going to try to measure it because we're doing the NDSR. And so we're measuring the HEI score for both groups. But if cash is helping people by reducing their stress, and then that ultimately improves their outcomes, that's really good to know. So that's one of the whole reasons that we have the two arms to begin with, is to try to tease apart that connection between stress and food insecurity.
Yeah, and similarly, so in our surveys, we asked people basically on both groups, for the food group as well, is like, how much of the box did you eat, and who was fed out of the box, basically. Similarly with the cash, where did you spend it and what did you buy, with no judgment, and we say that right up front, mostly because we want to see whether are they paying bills. I don't think we're as worried about them buying foods that we might not put in the list, but more so that are they paying, like as Alyssa said, are they paying off something that reduces their stress?
And you can kind of think like there's a difference between a food insecurity intervention and a nutrition intervention. And certainly I would expect that the home delivered foods, like some of the hope and hypothesis is that if you are really reducing barriers to making decisions around like what is good for me to eat while I'm pregnant, what's healthy for me and my baby, like you can really have a lot of overload when it comes to thinking about what to do. So hopefully we're reducing some of the stress and the barrier around that with the actual food. So we're hoping to see the nutrition improve through that intervention, but ultimately it will be very interesting to see what the differences are.
There's a question about CHW retention, and we do a lot through the Pathways Hub, and it's a bit of a victim of our own success, because I think what's great about the Pathways Hub is that there is a mandated amount of training and sort of workforce development that goes up as a part of being a trained CHW in the Pathways Hub. And again, great CHWs are worth their weight in gold. Like, they're just remarkable. But what happens is they move up the ladder and they become supervisors, or they then train CHWs, and it's this cycle. And it's no different than medical assistants or any kind of situations that happen in the healthcare space. What you want to create is a sort of an onboarding process that trains and sort of supports, identifies good potential CHWs, and we have a lot of really good grants that we're working on across the Pathways Hub to better do that. And then two, how do you help agencies to better sort of train and onboard them when they come on, which is harder because, again, there's a decentralized problem. It's up to the agency to do that. And some agencies are very, very good at it. Some agencies are learning how to do it a little bit better. So it's a tricky issue because, again, CHWs, I think are, again, a victim of their own success.
So there's a question about the distrust, and I think that kind of ties to, I don't know if I'd call it the distrust question. I think is that, have you found there's a level of distrust among potential participants in returning calls and learning about the program? I don't think distrust is necessarily the word. Because what we know is that once we get folks on the line, then they're very interested and they stay with us, right? I think one of the biggest, I would call it cognitive overload or burden, like our cognitive burden, is that I think these folks, by the time, now mind you, now especially if they have other children, now they're pregnant, and a lot of people are reaching out to them. I mean, I think there are a lot of programs that are available to them, not necessarily around food. And so there's also just how much can they do in a given day, right? And so answering phone calls, how many of us don't answer our, we get a cell phone, right? And do we answer them? And so, it takes sometimes the CHW calling them and then us calling them. It just, as Chris showed you in the QI stuff, is that the time is that it can take many, many calls until we basically can connect with them. So I don't think that there's a distrust necessarily. We do think there might be some stigma around the food boxes, but we haven't really delved into that that much. It's come up a few times. But I do think that the biggest issue is burden. And we should say too that, the hub, one of the biggest advantages of the hub, particularly for the study, if you've noticed that the folks are not referred from a provider, right? They're being referred from the community. So these are CHWs out in the community, identifying folks in the community. Now, there are healthcare providers. We have a large hospital that does have CHWs that does this, but they're coming from the community itself. And so we don't have a direct line to their health data, right? So this is the hub's one of the biggest roles of the hub is this systematic data that they collect, right? And the pathway. So we also have a really good idea of what other social services they're receiving. But the negative of it is, as we've been talking to Carrington and the other folks from RWJ, is that, you have an agency who has CHWs. So they recruit a person, they do their intake. Then they recruit them into the hub, and then there's a whole big intake in the hub. Then they come to Nourishing Beginnings, and we have a baseline survey. Like, talk about burden, right? And we want to do this all within, a week's period. And we ask them for 2 24-hour recalls, right? Food recalls. It's a lot. It's a lot to ask anybody. And now we do incentivize them, but there's clearly I think it's just, personally, I just think people are just, I can't do anything. I've done, making decisions, decision fatigue is another word that's been used, right? Yeah. So I don't necessarily think it's a distrust. I think it's more of a, I got too much going on.
But also, like, that was part of the intention of the community health workers, is that hopefully there is a nice established trust there between the community health worker and the folks that they're working with. But it was definitely worth it to gain the trust of the community health workers themselves, because the population that we're hoping to work with is a highly studied, recently surveyed, piloted group of folks, and they're a little bit tired of it. So, I think this can be kind of protective of their people. So we had to really spend some time getting to know them and talking about our intentions in the program at the get-go.
And we should say too that we like in the development of this, the CHWs have played a significant role in the development of how Nourishing Beginnings got rolled out and how they participated, how they would introduce it, how the interventions introduced. So it's been participatory from that end. We have not involved that many individuals at the community resident level or the pregnant individuals, other than just getting feedback through qualitative interviews. That will come, but I think at this point we're again trying not to burden them too much in terms of feedback. Is there anything else in here that? Languages, we have English right now. Spanish is, so much of this is dependent on the CHWs. And so whether we have CHWs that are fluent, we have fluent folks at the data collection side. So we're able to do from the study side, but not necessarily from the intervention side. So it's dependent basically whether the CHW is able to interpret or, translate. What else is on here, Carrington, that you see? Anything that we didn't?
There are a lot of questions. I'm reading through them at the same time as you are. So if you see that you want to answer, feel free to jump in. I see some that you've already addressed.
Yeah, the question on the CHW handoff, I love that, because I think this has been its own quality improvement. So early on in the hub, and those who run hubs on the call will kind of attest that there was a habit of taking referrals from payers. So they would sort of give us a long list of, hey, this is someone that's on our rolls and we know they're pregnant, can you contact them? And the contact rate of that was less than 5%. So it was just, and it was a low morale issue. It was just, the numbers were bad, just no shame to anybody, but it was a bit of a paperwork problem. As we've moved more towards community referrals, so as CHWs are out in their community and they're finding somebody, the success rate of those is so much higher. So I do think that there is a value in that they're meeting someone in the community and saying, hey, I think you'd be great for this study. Would you be interested? And that's like, within a day, we're getting that person. And learning about sort of all those different elements is really hard. But that's an example of how that warm handoff really can help. But is it scalable is the hard thing, because you're only getting a certain type of clientele in those fairs, where sometimes the folks that you want to reach are going to be harder to reach. And I think Elaine brought this up, and the data we have, I mean, about I think 15% or so of the pregnant clients move during their pregnancy. So they're changing cell phone coverage, they're changing addresses. So it's a bit of and then you just have the coordination issue of a bit of a phone tag. And again, especially since we're dealing with a very short time period that we need to get them on, that's why so many of them end up aging out.
Thank you, Chris. I think we maybe have time for one more question. And I know we still have a couple in here that have been entered into the Q&A box, and we can give these to the presenters and see if they're able to address them, and we can share some of their answers in our follow-up email. But for a last question, one from Ailey Joseph here about the outcomes of interest and intermediate intervention impacts that you discussed. Their question is, in order to achieve these outcomes, how dependent are you on adherence to implementation fidelity? And are there challenges among the community health workers and agencies?
I'm just looking again here. Good question. I mean, there's so many layers to this, right? This is still somewhat of a pilot from our perspective to work out. The best thing about the food box piece is that we do have really good data on that adherence, right? At least from the delivery standpoint, from an implementation standpoint. Now, what folks do with once they get it in their house, we don't know. But I do think that, somebody could criticize and say, well, how do you know they're eating everything in the box? We don't. Our implementation is basically getting that, basically the food bank is, getting it to that person's home and knowing that they picked it up and took it in the house. I don't know, Alyssa, are you still on, or did she have to go?
She just dropped.
She dropped, yeah. Mm-hmm. So I don't know if that helps or not, but, depending on, I think, and whether we'll really be able to, narrow this down. I think our biggest thing is going to be once we get the propensity scored matched sample. I think that'll tell us a lot more too, because we also feel like this is a very, very at-risk group than average. And so it is hard and we're comparing them to two groups getting an intervention, right? And so there's a lot going on in this from a study standpoint. I didn't know if you want me to share so you guys could, want to make sure that you have your.
Yeah, if it's easy, you can go ahead and bring the slide up since we do have a few announcements. I think I'll follow up on your last comment and just say stay tuned, because this research team will come back in the future for another research in progress webinar. So maybe you can hear more about some of their findings at that point in about a year, but we'll keep you updated on when they'll be back. But thank you so much for coming and presenting today. It was really interesting to hear all of the things that are going on in your research project and hearing some of these important and interesting updates. And thanks to everyone for joining. If you would like a certificate of completion for today, there will be a very, very brief survey whenever we end. And if you can indicate if you would like a certificate, and we will get one to you in a timely manner. And then next slide, please. And as we mentioned at the top of the hour, this is an ongoing series that we have where we invite our Systems for Action researchers to come and present on their ongoing research projects. Next week, we are going to have a team from the University of Minnesota presenting on their project titled Social Bonds as Pooled Financing Mechanisms to Address Social Drivers of Health Equity. We will include a link to sign up for this if you're interested in attending in our follow-up email, along with the slides and recording from today. And I think that is it for all of my announcements. So I think we'll go ahead and close out just 1 minute past the hour. Thank you again for attending, and I hope everyone has a great rest of their day.
Thank you, everybody. Thanks for coming.